This is Dr. Saad, and as you know, we're recording series of lectures for pharmacists who are going to appear for international equivalency exam. So let's resume our topic, and new viewers requested to go and watch our previous video so that you can get our preparation plan. As we were discussing about the schizophrenia, and last point was missing, that is the tardive dyskinesia. And let's resume our topic, and then we will move on our next topic. And as long as the travel dyskinesia is concerned, it happens uncontrolled facial movement. Example of that movement is rapid blinking, lip smacking, and tongue thrusting. And you can say it happens. Why it happens? It because of cholinergic acetylcholine deficiency. So we have two-step approach for the management of tardive dyskinesia. Number one is we will shift patient from typical antipsychotic drugs like represidone, paliperidone to the atypical antipsychotic drugs. That example is the quetiapine. Its dose is 150 to 800 mg, and clozapine, whose dose is 300 to 600 mg. This is our first approach. Secondly, we will eliminate all drugs which are causing or reducing, as you can say, which are causing anticholinergic effect. That example is the anti-Parkinson drugs and tricyclic antidepressants. And once we have deployed these two approach and patient is still showing the symptom of tardive dyskinesia, then we will move to our third approach. That is the we will use benzodiazepines class drug, that is the diazepam, with a very high dose, that is the 30 to 40 mg per day, to manage this situation. So this was all about the tardive dyskinesia. And the next point number two is about the drug, that is the ziprasidone, whose dose is 80 to 160 mg, which causes QT prolongation. So CVS patients must be take very care while using this medicine. So this was all about our points. Now we will talk about a summary of this chapter relevant with just schizophrenia and conclude it. So let's discuss all subclasses and some of its example. First is the phenothiazine. Its example is the clorazepam. Its dose is 100 to 1000 mg per day. Second example is the fluphenazine. Its dose is 2 to 60 mg per day. And third example is the thioridazine. Its dose is 100 to 800 mg per day. These example belongs to the phenothiazine. Second is the thioxanthine. Its example is the thiothiazine. And the third subclass is the butyrophenone. Its example is the haloperidol. Second generation antipsychotic drugs, and its examples and doses are, and examples are aripiprazole, belongs to the second generation antipsychotic drugs. Its dose is 10 to 20 mg. Brexapiprazole, it's also example of this subclass. And caripiprazole and clozapine dose is 300 to 800 mg, as we discussed before. Lurasidone and olanzapine 10 to 300 mg, and quetiapine 150 to 800 mg dose. Ziprasidone 4 to 16 mg per day dose, and represidone dose is 4 to 16 mg, and ziprasidone dose is 80 to 160 mg. These drugs belongs to the second generation antipsychotic drugs. And lithium is used for bipolar disorder, and other agents used for bipolar disorders are carbamazepine and lamotrigine and valproic acid. So this was all about the summary of all drugs which would about and classes, subclasses, and their example, about which we talk in previous chapters, and their relevant technical points. So now let's move on to our next topic, that is the muscle relaxants. Muscle relaxants are divided in two major therapeutic group. Number one is that which we can say which is used during surgery or intensive care units while procedures of anesthesia. This all drugs which belong to them is known as neuromuscular blocker. We'll talk about them in detail in when we'll discuss anesthesia chapter in upcoming lectures. And second group, therapeutic group, reduce the muscle spasticity and painful condition. It is also known as antispasmodic drug or spasmolytics, spasmolytics or antispasmodic drugs. So first of all, we'll talk about these drugs. First of all, first example out of our antispasmodic drugs are tizanidine. tizanidine, and its initial dose is 2 mg 6 to 8 hour, and it can be titrated to maximum up to 36 mg per day. Point number two is about the cyclobenzaprine. It's a structurally analog to amitriptyline, and which has amitriptyline, as you know, which has side effect of anticholinergic alpha blocker. It causes weight gain. So cyclobenzaprine can also have this side effect. This cyclobenzaprine is specifically used for voluntary muscle spasm, and it is and point number. This is all about the centrally acting so you can say centrally acting spasmolytic drugs. Point number three is about the muscle fatigue. Muscle fatigue is due to lactic acid accumulation. So it was an out of our previous concepts. Point number four is about the baclofen. It also belongs to the class known as centrally acting spasmolytic drugs, and its dose is 15 mg BD and increase it, and you can say its maximum tolerance dose is 100 mg daily. It's also centrally acting. Point number four is about the depolarizing neuromuscular blocking agent, and its example is the succinylcholine. And point number eight is about the non-depolarizing muscular blocking agent, neuromuscular blocking agents, and it's whenever it this is very famous drug which known is rocuronium. Whenever curonium, you listen about the word curonium, you will easily get this idea that it belongs to the non-depolarizing neuromuscular blocking agents. Other examples are tubocuronium and cis-atrocuronium. These are the example of this drug. Next point is about just a review about the centrally acting antispastic drugs, as we talk about the baclofen and diazepam and tizanidine and cyclobenzaprine. These are the drugs which belong to this class. Our last point from the skeletal muscle relaxant class, that specifically other than the anesthesia, is the direct acting muscle relaxants. First example, its example is the dentroline. Its dose is 25 to 100 mg QID, and it causes skeletal muscle relaxation due to inhibit the flow of calcium. Second example is the botulinum toxin. As we talked about it, it inhibits the release of acetylcholine in ANS. You can easily review once you have listened our ANS lectures. So just review ANS videos first, then move on the central nervous system. Then your concept will be strengthened more, because many other concept depends upon the ANS drugs. So this was all about some very little about the skeletal muscle relaxants, specifically that therapeutic group which belongs to the muscle spasticity, or you can say antispasmodic, shows them antispasmodic action for various painful condition. So let's move on our next chapter, that is the narcotics. In this we will use opioid derivatives, drugs which is used for alcohol withdrawal, and other drugs which can be abused. We'll talk about them. So let's begin our topic without wasting more time. Point number one is about vitamin B6. Vitamin B6 is used in alcohol toxicity as it decreases the alcohol level. So vitamin B6 is very important. Point number two is about the treatment of, you can say, treatment of opioid withdrawal is methadone, and it's given OD. Methadone is used for the treatment of opioid withdrawal, and its dose is once per day. Point number three is about, so this chapter is very lengthy, so we'll try to my best to move quickly toward the point so that maximum concept will be recorded in a minimum time. Point number three is about the constipation due to codeine. And how we will treat it? We'll use stimulant laxative. We will use stimulant laxative, not enema or bulk laxative. Specifically, constipation relevant to codeine. Point number four is about the treatment of alcohol withdrawal syndrome. It's you can say we use benzodiazepine class. An example of that class drug is chlordiazepoxide, and its example is its dose is 10 to 30 mg TDS, and diazepam 5 mg BD, and lorazepam 1 to 2 mg OD or BD, or oxazepam. We will use benzodiazepine class drugs for the management of treatment of alcohol withdrawal syndrome. And point number five is about the you can say uh, thiazide diuretics. Thiazide diuretics and its interaction with the amphetamine. Amphetamine is a strong CNS stimulant, and it is actually used for attention deficit hyperactive disorder. Disorder, and when you will use with the thiazide diuretics, here you will observe an interaction. That interaction is thiazide diuretic enhance the action of amphetamine. So amphetamine actions enhances, so it can be very serious once you are getting a therapeutic effect, and it effect will produce more because of thiazide diuretics, because thiazide diuretic enhances the action of amphetamine. Point number six is about the theophylline. Theophylline half-life decrease in smokers because smoker increase the metabolism of theophylline. So theophylline actually belongs to the xanthine derivative class that causes relaxation of airway, and it isn't used for the it's you can say it isn't used for arrhythmia, but it's specifically used for respiratory system associated disease because it causes the muscle relaxation around the airway. So once a smoker is using this medicine, then theophylline half-life is, you can say theophylline half-life decrease in them. So we may need more dose in smokers because of their increased metabolism due to smoking. Point number seven is the codeine. Sorry, point number seven is about the side effect of codeine and morphine, because morphine codeine is derivative from the morphine, so its side effect is nausea, vomiting, constipation, and respiratory depression. These are the common side effect of codeine. As we talked about it earlier, that we will use stimulant laxative for the management of constipation. Similarly, we'll talk about how this respiratory depression affects our other treatment plans, specifically in management of pain anesthesia. Point number eight is about the respiratory depression causes death in cocaine poisoning, and opioid-induced respiratory depression remain one of the most clinical challenge in the treatment of severe pain. As we talk about right now, that respiratory depression causes death. So once we are using opioid to for the management of pain, then is respiratory depression, which is the side effect of this, you can say opioid poisoning or opioid drugs, it becomes a serious challenge. So here we have to be very conscious about it, that this respiratory depression can even cause death. But if a person is exposed to cocaine, its poisoning can cause respiratory depression and death. So these 2 points must be kept in mind, that respiratory depression even cause death, as well as while setting therapeutic plan for the pain management by the use of opioids, this respiratory depression also creates a challenge for the therapeutic planning of pain management. Point number nine is about the morphine allergy. Patient with morphine shouldn't take codeine chemical related. Yes, patient with morphine allergy shouldn't take codeine because codeine is derivative form of morphine. If patient is allergic to morphine, he will also show allergy with the codeine. But this effect is specifically limited with the codeine, not with other drugs. For example, if you are using mipyridine, whose brand name is Demerol, whose brand name is Demerol. It's the brand name of mipyridine. If you are using this and person is morphine allergic, there's no issue. Similarly, pentazocine, whose brand name is Telvin. If you it is also okay with morphine allergy. Methadone, whose brand name is Dolofine, it is also okay with morphine allergy. And similarly, butorphenol, but, butophe, but, butor, butor, sorry, butorphenol, its brand name is Stadol. It's also okay with the person who is morphine allergy, but only you have to avoid the use of, you can say, codeine if person has a morphine allergy. But you can easily use mipyridine or pentazocine or methadone or butorphenol, as I told you about some of the brand name, because sometimes it can also be asked in exam with respect to the brand name. And so let me repeat once again about it. The mipyridine brand name is Demerol, and Telvin is the brand name of pentazocine, and dolufene is the brand name of methadone, and Stadol is the brand name of butorphanol. These drugs are okay once person is allergic with the morphine, but codeine is contraindicated. Point number 10 about the narcotics is about the disulfiram, naltrexone, and acamprosate. Disulfiram, naltrexone, and acamprosate. It is FDA approved drugs for the treatment of alcohol withdrawal, alcohol dependency. This is the specifically approved for alcohol dependency, and this is used for management of avoid the addiction of alcohol. As long as you can say this disulfiram is concerned, here is another point relevant to that I would like to share. It is disulfiram is a specifically used for chronic alcoholism by producing acute sensitivity to ethanol. How do it cures the alcohol dependency or chronic alcoholism? For the chronic alcoholism, it inhibits the enzyme which name is that aldehyde dehydrogenase. What does this enzyme do? It actually, if once person consumes alcohol, you can say once this enzyme is inhibited, many of other effect of hangover lie to be felt immediately following alcohol consumption. One person consumes alcohol and using side by side this disulfiram, so this effect of hangover to be will be felt immediately after alcohol consumption. So because of this hangover effect, addictive person will feel irritation while using or consuming alcohol. So in this way, patient will be cured by the use of this drug. So this that's why it is approved from the FDA for the treatment of chronic alcoholism, or you can say treatment of alcohol dependency. Its example once again is the disulfiram, naltrexone, acamprosate. But this effect which I told you put hangover, it is specific hangover effect. It is specifically linked with the disulfiram. We will talk about this concept again in a detail.